It's 9 at night. The clinic closed hours ago, but the doctor who saw you today is still working. Not with patients, but at a keyboard, finishing notes and clearing an inbox that never empties. Physicians have a name for it: pajama time. And it's a symptom of something the data has been signaling for more than a decade. In the outpatient practices, researchers have actually put a stopwatch to: for every hour a doctor spent face-to-face with patients, they spent close to 2 more on the electronic record and desk work. The people we trust to care for us are worn down. And increasingly, it's not the medicine that's exhausting them. It's everything piled around it. Why are so many doctors burning out? Let's follow the exhaustion. American healthcare generates a staggering mountain of administrative work. The billing, the coding, the pre-approvals, and the compliance paperwork we mapped in the last episode. This one is about where a lot of that mountain lands, on the backs of the physicians themselves. This episode focuses on doctors, whose burden has been measured most closely. Nurses face a serious, related crisis with its own distinct drivers, and it deserves its own episode. Because here's the crucial thing the evidence keeps showing. Physician burnout isn't mainly a story about individuals who can't cope. In the data, it tracks the operational load a doctor carries per patient. The documentation, the message inbox, the pre-approvals, the productivity targets. When you make caring for a patient require 2 hours of typing for every hour of talking, you don't get lazier doctors. You get exhausted ones. Let's look at what's actually driving it, and in fairness, at what genuinely helps. Let's answer it like an operator. Why are so many physicians burning out, and what would actually move the needle? The story runs through a measurable explosion of documentation, a fierce debate over whether we've even named the problem correctly, and a body of evidence about what helps and what doesn't. One framing to keep in mind the whole way through: the question isn't whether individual doctors should be more resilient. It's why we've built a system that exhausts even the resilient ones. Let's dig in. Start with the scale. In the big national studies led by researchers at the Mayo Clinic, physician burnout has moved in a clear arc, around 45% in 2011, dipping to 38% just before the pandemic, then spiking to a record 63% in 2021 and easing back to about 45% by 2023. Two honest caveats: burnout is self-reported and different surveys use different definitions, so exact percentages aren't perfectly comparable, but every serious measure lands in the same place: a large share of doctors, year after year, running on empty. The pandemic made it worse. It didn't create it. The baseline was already alarming. So what's eating the day? A landmark time and motion study followed physicians in several outpatient specialties with a stopwatch and found that for every hour of direct patient care, they spent nearly 2 hours on the electronic health record and desk work. Only about 27% of that clinic day was actual face time with patients, and even inside the exam room, barely half of it. Add 1 to 2 more hours of pajama time at home each night, mostly finishing notes. That was a limited sample, not a census of every US doctor, but the pattern has been corroborated widely since, and it's the mechanical core of burnout. Most people who went to medical school did it to take care of patients. The job increasingly asks them to take care of the record instead. The load has specific, nameable parts. There's the electronic record itself, a blizzard of clicks, drop-downs, and safety alerts, much of it existing to satisfy billing and legal requirements rather than to help the next doctor. There's the in-basket, the never-ending stream of lab results, refill requests, and patient portal messages, which surged after 2020 and is mostly unpaid and unstaffed. There's prior authorization and the documentation needed to justify every billing code. And underneath it all, productivity targets that reward volume and a steady erosion of the clinician's control over their own schedule. The National Academy of Medicine, reviewing all of it, reached the obvious conclusion: this is a systems problem, not a character flaw. Put one number on the spillover. In one analysis, family physicians spent about 86 minutes, nearly an hour and a half, on the electronic record after hours, at home, every single night. That's time taken from sleep, from family, from rest. an invisible second shift that shows up on no schedule. And prior authorization piles on. By the main physicians group's own survey, a group that campaigns against it, so weigh the figure accordingly. A typical practice spends around 13 hours a week clearing pre-approvals, and nearly 90% of doctors say it worsens their burnout. Hour by hour, the system asks clinicians to give up the parts of the job and the life they actually value. There's a deeper argument here about the word itself. In 2018, two physicians, Simon Talbot and Wendy Dean, argued that calling this burnout quietly blames the doctor. It implies they lack resilience or grit, and that the fix is to toughen them up. They proposed a different term, borrowed from combat medicine: moral injury. The distress, they argued, doesn't come from being weak. It comes from being forced over and over to act against your own judgment, knowing exactly what a patient needs, but being unable to give them the time, the test, or the treatment the system allows. On this view, the burned-out doctor isn't broken. They're a working conscience trapped in a broken machine. And the reframe matters because it moves the target of the fix from the person to the system. Now, in fairness, the reframing has critics, and they have a point too. Burnout, as originally defined, emotional exhaustion, detachment, a shrinking sense of accomplishment, is a measurable syndrome with more than 40 years of comparable data behind it. Moral injury is a powerful explanation for a major cause, but you don't have to throw out the measurement to accept the diagnosis. Most thoughtful people in the field now hold both. The system is the driver, and burnout is still a fair name for the state it produces. And individual support, peer groups, mental health access, coping skills, genuinely does help real people. The failure mode isn't offering those things. It's offering only those things, while leaving the crushing workload completely untouched. This is where the evidence gets sharp. A major meta-analysis in The Lancet found that both individual-focused programs and organizational changes can reduce burnout, but the structural organizational fixes tend to work better, which lands hard on a favorite corporate response: the wellness webinar, the meditation app, the resilience training. Those aren't useless, but against a 2-hour-a-day documentation burden, a mindfulness module is a teaspoon against a flood. And there's a subtler harm. When an institution's answer to a systemic problem is, "Here's a yoga class," it can read as blaming the clinician for a machine they didn't build. The message accidentally becomes, "The problem is you." So what does work? Credit where it's due, the fixes with the best evidence all share one feature: they cut the actual workload. Hawaii Pacific Health ran a program it literally called "Getting Rid of Stupid Stuff," inviting staff to nominate pointless clicks and required fields for deletion, and removed millions of needless documentation actions. Medical scribes take the note writing off the doctor so they can look at the patient instead of the screen, and increasingly, ambient AI that listens to the visit and drafts the note is an early but promising version of the same idea. Though its evidence base is still young, so treat it as emerging, not proven. Add team-based triage of the message inbox, switching off the flood of low-value alerts, realistic patient panels, protected time to chart during the workday, and giving clinicians a real say in how their day runs. None of it is glamorous. All of it attacks the load itself. That's the tell, the things that help take work away, not the ones that ask the clinician to absorb more of it with a better attitude. And this isn't only a human problem, it's an operational one with a price tag. Burnout drives doctors to cut their hours or leave altogether, and replacing a single physician can cost anywhere from $500,000 to over $1 million. One peer-reviewed estimate put the total cost to the US health system at about $4.6 billion a year, roughly $7,600 for every employed physician, just from turnover and reduced hours. A burned-out workforce isn't only unhappy, it cuts back and it quits, and that deepens the very shortages that made everyone's workload heavier to begin with. It's a doom loop. And there is a cost that matters more than any dollar figure. Burnout is linked to higher rates of medical error, so the harm doesn't stay with the clinician. It can reach the patient. And at the far end, the toll becomes personal in the hardest way. Physicians, and especially women in medicine, have historically faced elevated rates of psychological distress and suicide compared with the general population. The encouraging news is that the most recent research shows that gap narrowing and its exact size is genuinely debated among researchers. I won't dwell on the details. The point is simply this: when we talk about clinician burnout, we are ultimately talking about human beings under real strain. And that is the strongest reason of all to fix the system straining them. So here's the whole thing on one card. 1. Burnout is mostly a workload problem, not a resilience problem. The system exhausts even the strong. 2. The biggest drivers are concrete and fixable: the documentation, the inbox, the pre-approvals. 3. Wellness apps and resilience talks on their own can't offset that load and can even insult the people carrying it. And 4. The fixes that actually work all do the same thing. They take work off the clinician's plate. Fix the workload, not the worker, and support the worker too, because that genuinely helps. It just can't be the only move. That's the whole lesson, and the data has been pointing to it for decades. If you take one thing from this, make it this: when you hear that doctors are burning out, resist the reflex to picture people who just couldn't handle the pressure. The clearer picture is a workforce buried under administrative work the system manufactured. The billing, the pre-approvals, the endless documentation, now landing on the person at the bedside. The exhaustion is a system's output, which means the cure is mostly systemic too. And the next time an institution answers burnout with a meditation app while the inbox keeps overflowing, you'll know exactly what's missing. Not more resilience from the doctor, that has its place, but far less pointless work from the system. So the next time your doctor seems rushed, or you picture them still charting at 9 at night, you'll understand it isn't a personal failing. It's the human edge of a system that generates far more paperwork than it needs to. We've followed that paperwork through hospitals, insurers, administrators, and now the clinicians themselves. Next time, for the finale, we pull the strangest thread of all, the one piece of 1980s technology that somehow still holds the whole system together. Why, in the age of the smartphone, American healthcare still runs on the fax machine. For more on how the system really works, visit shanewelter.com. I'll see you in the next one.